Wonderful. So hi everybody. This is the last of our series of webinars aimed mainly around primary care. It's fantastic to see you, and if you're joining us on the recording, then it's really great that you've managed to join us. Thank you. My name is Fiona Rawlinson and I'm a consultant in palliative medicine in City Hospice in Cardiff, but my background is general practice quite a few decades ago, but that's where I came from, so it's wonderful to be working back in the community. And if you've been part of these webinars over the last 5 weeks, you'll also know colleagues. So can I let James introduce himself first?
Hi, yep, I'm James Davis. I'm a consultant also working in City Hospice. I don't have a background in GP, so I'm a pretender.
Thanks, James. And Catriona?
Hi, my name's Catriona Seed. I'm one of the clinical nurse specialists, also from City Hospice.
That's fab, thank you. And Charlotte, do you want to introduce yourself as well, just for completeness, please?
Hi there, I'm Charlotte Stevenson and I'm one of the business development managers at Cardiff University, and we're here just to facilitate and support these online learning packages.
Wonderful, thanks Charlotte. So I can see we've got a couple of people joined us, which is wonderful. I wonder, there's probably not enough people to to do a great poll, but would you like to just put in the chat where you're working, what you're working as and where you're from? That would be just really helpful just before we get going, so I've got a sense of who's in the room. The topic for today's webinar is thinking around difficult, it's really how to respond or to start difficult conversations, and we felt that it was relevant to put this as the final one in our group of 5, just because there have been themes through the last 4 webinars around communication skills, and so very much we're not pretending that we've got all the answers. This is not that sort of a webinar. This is a webinar where we've got a chance to share ideas, share useful phrases, think about what we feel like when we're slightly put on the spot with what I call unanswerable questions. I've been in palliative care now for over 30 years, and there are still moments when I am asked the unanswerable question, and because of the house I'm in, the people I'm with, the family dynamic, at the point that that question is asked of me, I'm sitting there, and although I might look very calm on the outside, on the inside I'm thinking, oh my word, what am I going to say? How can I possibly answer what for this person is a really, really big question? So it's very much, that's the theme of this webinar. We've called it How to Respond to or Start Difficult Conversations, but it's very much, this is an opportunity to share practice. So wonderful. Thanks, folks. Thanks, Lauren, for putting in the chat where you are. If people could put in the chat who they are, where they're working, that would be great. I'm going to share my slides. I'm going to share some slides, though. We've got points of chat through the next sort of 20, 30 minutes or so. And so I'd really encourage you to put your views in the chat, put your thoughts in the chat. And actually, because we haven't got a huge number of people, you can put your hand up and we can actually have some verbal interaction, which makes life much, much more interesting. Be aware that this is being recorded. It will be available open access on the CPD channel, though. So, usual confidentiality around patient information or colleagues. We need to be mindful of that. And the final thing to say is that we will finish the recording at 3. But if there are things that people want to chat about for the 10, 20 minutes or so after the webinar's finished, then that option is also there as well. So keep your fingers crossed, chaps. I'm going to try and share my slides now. And what I'm hoping is that I am sharing my slides, because of course I can't now see anybody. So Catriona or James, could you just reassure me?
I can't see them at the moment, Fiona.
Okay, that's good. That's exactly the right answer I was looking for. Thank you. I'm going to try again. I have a feeling it probably needs to be this one. Does that look right?
Yeah.
Okay,
Perfect.
and I'm now going to put it on presentation, I hope. Oh, and that's what it's. So does that still work, James?
It's not as the as sort of a slideshow, so you can see it, but you can just see all the slides on the side as well.
Okay. That's really interesting, and I don't know why that is. We'll have one more go, and then if it doesn't work, forgive me. I might just, in the interest of time and want to get on and to hear what people think, we'll have one more try. How about that?
Yeah, perfect.
And hang
Third time
on.
lucky.
Yes, but is it going to the next slide?
Yeah.
Hurrah! Wonderful. Okay. We're very much hoping, as you heard, so myself and James and Catriona are from the City Hospice end of Cardiff. We're very much hoping that Elaine will join us from the Penarth Barry end of Cardiff, because these webinars have been Cardiff and Vale. So, right, what are we thinking about? Communication skills in general, difficult conversations being part of that. How do we communicate when we're having these conversations? It's face to face. Yes, we've been through PPE. Yes, we've got virtual, we've got email, we've got phone, we've got being in the same room. But how often it is that actually what we think we've said, whatever modality of communication we've used, may not necessarily have been received in the way that we think it has. So actually communication, there's two bits of it, isn't there? There's broadcasting and there's reception. And one of the things that we'll come back to in the webinar is just thinking, how can we pick up during a conversation that begins to get sensitive, that begins to get difficult? How can we pick up that actually we're not being received? Something is blocking that communication from going on. And I think I would urge all of us on the call, anybody who's looking at this afterwards, to try to move away from this is good communication, this is bad communication. I think it's more productive to think about it of actually, was that an effective communication? Was the message sent, was it received? Have we moved forward in whatever sensitive issue we were trying to discuss? Or actually, was something blocking it? And if it was blocking it, is that something in the environment? Is it something in me? Is it something in the patient understanding? Where's that mismatch? Where has it just stopped flowing? Just because we are all human and these conversations are difficult. And it's very rare that you get a perfect consultation. It's wonderful when it happens, but it might happen in one house or in one appointment consultation, and then same situation, different person, different family, different house, different part of Cardiff. You say exactly the same thing and it goes disastrously wrong. So it's a really fluid thing. And I think the aim of today's discussion is just to think about the strategies that we all know and that we all use. Are we using them as effectively as we might? And then just a brief talk through some tools which everybody will be using as we communicate, but perhaps not necessarily as efficiently or effectively as we could. So that's the aim of it. But do please use the chat to put questions, put thoughts, put reflections. Because as I say, communication skills is a lifelong journey, isn't it? How we communicate is just part of who we are. But there may be ways that we can help ourselves to be as effective as we can in what's a really difficult situation. Life is going to end for this person. A family is going to lose that person. And it's not that they're going around the other side of the world, it's that they will take their last breath and they won't be there anymore. And that's big. And sometimes I think we forget how big that is, but that's big and that's different to lots of things. So what are we going to do? We're going to think about triggers, we're going to think about phrases, and we're going to think about useful tools for strategies and support. So I think the first thing to try, and I'm going to be brave now and stop sharing my slides for a moment, although actually that might be a bit too brave. So James, I'm going to ask you to put some of these down. But for everybody on the call, can you think and can you put on the chat what for you, where you work, what are the challenges in these sensitive and perhaps more difficult conversations when you are looking after patients with palliative care needs? As people are thinking, I'll start the ball rolling. In a sense, is for me, it is often the unanswerable questions. How long have I got? Do you think I'm dying, doctor? Or sometimes it's when there aren't any questions at all, and you're sitting there thinking, this is all looking very fragile. I wonder how much this person has prepared, knows, but they really don't want to talk with me. I was in a nursing home through 2 weeks ago with somebody who was absolutely exerting their autonomy, mental capacity, sharp as a nail. They were fully mentally competent to talk about things, to make decisions. But could I encourage talking about preferred place, whether they wanted to go to hospital or not? Did they understand what they'd been told in the hospital? Absolute block. And it was really quite challenging. James, what have we got? What have we got in the chat? Is anything there at the moment?
Yeah, so Lauren has said about responding to timescale questions, which I think is a very common one, isn't it? And one that I know as an F1 sort of foundation doctor, you dread that question, how long? Another one is unrealistic understanding, which I think is something we probably encounter more often than we'd like.
Absolutely, it's balancing up hope and uncertainty, isn't it? And that's so hard. And actually, do people really mean that they want to go across the world to the States in 6 weeks' time, or do they really mean that they want to go and climb Snowdon? You know, how do you disentangle that? Lovely, yes, James. From your point of view, anything else that you find hard?
I mean, I think it's difficult sometimes when you're meeting someone for the first time and you've got a lot of things to talk about and to cover. And if you're going to look after someone, you're sort of assess them holistically. You're looking at their physical symptoms, their social sort of difficulties or setup, psychological concerns they have, and then coming on to the to difficult conversations and difficult discussions, usually around it's around advanced care planning as a very broad thing, isn't it, as a broad concept. And so trying to sort of build a relationship with that person in a short space of time to allow them to trust you to talk about it, because it's their major things to talk about, and for them to almost bare their soul to you. I think you've got to quickly try and gain trust with that person. I think is one of the things, and time pressures come into that then as well, don't they? Because you've got to think about actually the next person you've got to see as well, and balancing up all that. But for that individual, they don't care about the next person, do they? It's about what they're saying. The other thing, just coming back to what you said, Fiona, the ones I do find tricky sometimes when you can't really read what's going on. I mean, it's almost easier when you've got someone who's angry or sad or crying or showing, quite extreme, not extreme, quite powerful emotions. It's the people who I think, I don't know, is this going okay? Are you angry? Are you sad? That it's those sorts of ones can be almost taking that one step further, is almost when it's going too well and you're thinking, hang on, what am I missing here? And I think we've all had consultations where we thought everything went well, and then you get some feedback and realize what you thought went on and what was discussed really wasn't what the person receiving that information took away from it.
It's back to broadcasting and reception, isn't it? There are two bits to communication. It's back to broadcasting and reception. Yeah, absolutely. Katrina, can I bring you in here from your perspective, from the CNS perspective? What for you are the situations that make you worried, bothered, anxious, even though you won't show it, but actually inside, what are the things that are tricky?
I think on top of what's already been broached so far, I think it's that element of collusion when family members don't want us to discuss things openly with the dying person, or if the dying person then doesn't want us to discuss with people important to them, and you're kind of stuck in the middle, aren't you? Because you've got to, in reality, if that person is wanting to have that conversation, we have a right to support them. And also, if we don't engage people in those conversations, we'll miss things, and we won't find out what's important to that person as they get less well. We won't get things in place for them as they deteriorate, and you end up with these crises. But family members, they mean it from the kindest place usually, but they don't always realise that actually sometimes they're causing more harm. They're worried about anxiety to their loved one, or, you know, they're going to give up, is a phrase we often get, when actually sometimes being able to sit down with people, when you've actually got through that barrier, if you've been able to get through it, often what you find is a sense of relief that they've been able to openly discuss it. But it's tricky every time, and it takes sometimes multiple visits and multiple discussions to slowly build up that confidence and that rapport to get somewhere, and it can be so challenging.
Thank you. Fab. Anything else people have put in the chat while we've been talking?
Nothing as yet, but please please feel free to, or even better, raise your hand and let us know what the difficulties you've had, because I'm sure, you know, we were talking before when we filmed, you know, we do this day in, day out, you know, having difficult conversations and, you know, teach on it and things, but we all still now have difficult discussions, difficult conversations, and things which don't go so well. So I'm sure there are things which you guys have found tricky over, you know, and it's the ones for me that where things repeat themselves. Hopefully they don't repeat themselves too many times, because you know that's part of learning, isn't it? By repeating the the same sort of patterns.
Let's go on. So actually, what are the themes in these conversations? And the themes are very often these. It's managing uncertainty in ourselves because we don't know. So the rapidly deteriorating patient and timescales, the question that came up, absolutely. We don't know. We don't know. We've got a kind of a sense, and on some of the previous webinars in this series, we've talked about some of the tools you can use, some of the time you can use, some of the indicators that are beginning to be present for us to use. But it's not exact science yet by any means at all. And actually then recognizing that there is this information and expectation mismatch. So actually, what does that lead us to do? It's going to lead us to need to break bad news, because the patients' and families' expectations might be something that is never going to happen. And so in terms of strategies, it's not necessarily a breaking bad news about a new diagnosis or a new thing, but we may be having to change people's expectations, and that balancing up hope and uncertainty. And that is such a difficult balance to do, and how effective we are at managing that balancing up hope and uncertainty very much sometimes depends on us and our mood in that consultation. And as James has said, if we're time pressured, if the patient is time pressured, whether it's actually they've got another appointment, or you can see somebody is deteriorating day by day by day, in which case that is definitely a very, very short time scale. So consultation models, there are loads, aren't there? And in general practice, we will have many more than my learning all those years ago, which was Roger Neighbour's consultation model. There's ideas, concerns, expectations. There's models and frameworks around breaking bad news, aren't there? There are things that we are taught are a useful way of using the time effectively when a patient comes to seek our help, or when we are with patients trying to help. Breaking bad news strategies, these are familiar to all of us, and as a framework, as a strategy, they will remain useful, as I say, whether it is breaking news around a diagnosis, the fundamentals of breaking bad news, but actually for bad news it may be, when I say simply, that's not quite the right word, but it may be a question of the patient and family's expectations is at one level, but in the time that is left for that patient, their physical condition is not going to allow that to happen, because they have got an advancing, incurable disease. And so we're going to need to reset expectations. But for the patient, that might still be bad news. So kind of being agile enough in our thinking, in our frameworks that we've got, the tools that we've got, is really useful in a consultation, because once you recognize that actually there is a mismatch here, okay, so actually I might begin to be breaking bad news. So am I in the right place? Am I in somebody's house? Have they come to see me? Have we got 14 neighbours, 15 cats and dogs around us? Is it quiet enough? Can I do anything about the environment? Possibly not. So what do? You do the best you can. You know, when you're in somebody's house, you've got no option sometimes. You have to do the best you can, but just think about that physical environment. So setting up the interview, actually exploring, just tell me a little bit about that. So you want to go and climb Snowdon at the end of August. Tell me a little bit about why is that important to you? Seeking information to help understand the situation can be incredibly helpful. And actually, how much do you want to know? Is this a conversation that we should have now? Have you got everybody around you? The warning shot's terribly, terribly important when you're breaking bad news. And for those of you who've seen Nikki Pease from Velindre Hospital talk about communication skills and the Cardiff 6-point toolkit, she also brings in the chimp paradox, which is the most fantastic book around just really describing our own behavioural wiring and how the brain works. And if you're given bad news, if your version of what the world is going to be like is suddenly changed without warning, generally the human reaction is one of fight or flight. But actually what that means is lots of noise, mental noise, and you don't hear anything else. So actually the warning shot about, I think this is something we might need to talk about, is now a good moment. Or the rest of your family's outside. Is that something that you wanted that we perhaps should bring in with you? Or if you're setting up an interview in the surgery, do you want to bring somebody with you that day? Just the warning shot will help bring people into a place to expect that they may have something unexpected in the information and in the communication after that. And actually, sometimes the warning shot can be something as simple as, I'm really sorry, we've got some bad news, or I'm really sorry, there's something that we really need to talk about. But it's just, rather than launching straight in, which is such a temptation because generally we're anxious, having that steady warning shot is really important. Giving the information, whatever it is, and allowing time for an appropriate reaction to happen, which may be tears, it may be anger, it may be withdrawn. It depends on the person in front of you. But actually, we have to hold our nerve and allow that reaction, summarising, planning and follow-up. So the breaking bad news strategies are really helpful as strategies. But what I'd like to go on to is just quickly think about some of the tools that might be useful to deliver the strategies, and then we'll stop and just have, discuss about actually whether you will be using these tools. You might not have kind of thought about them as tools, but we all use these tools all the time, and it's been terribly helpful. But the tools need to be appropriate to the task in hand. So my slide here is, would you use a hammer to mend something as tiny as an earring? So again, colleagues in Velindre, Nikki Pease and colleagues, developed these 6 tools. They're tools in a toolkit. They're not in a particular order, but they're just useful tools to help, if you like, steady us through these difficult conversations. And they're all things that we will all be doing. Comfort, for example, the tool comfort is not just the environment. And as I say, sometimes you can't do much about the environment. You have to just make it as good as you can, allowing for the fact that there may be 14 neighbours, cats, dogs. I went on a visit a couple of years ago, and the person I was visiting was very much the matriarch, not of her family, but of the street. So as I was trying to have a sensitive conversation around preferred place of care and preferred place of death, all sorts of people kept wandering into the kitchen and out again because they were concerned about what was being said. In fact, I think they were a little bit worried that City Hospice had rocked up to see somebody who was a real pivotal figure in the community. And so actually, I think they were checking me out and checking City Hospice out as well. And hopefully we did the right thing. Well, I think we did, because things went fairly smoothly after that. But there is comfort for the patient. Are they in pain and you're trying to have a difficult conversation? That's never going to go well. So are they physically comfortable? Is the family around? Are you comfortable? My favourite slide, which I haven't put in actually this particular webinar, are you hungry, angry, late or tired? You may be all of those things because we haven't got control over our days. But if you are, you just need to understand that your communication skills may just not be quite as highly tuned as you'd like to think they are. We're all human. It's a fact of life. So just thinking about your own comfort as you go into these consultations, whether it's in the house or the surgery, is useful. And just a quick parallel now onto phone consultations or virtual consultations, which can be so useful as part of our armoury, if you like, can't it? But actually, sometimes I think we don't pay attention to the comfort in those modes of communication. So actually, have you set up that? Are the patient expecting you to ring? Is it an okay moment? Are they in Tesco's with 14 children around them and lots of bags? Are they driving? So actually just setting up comfort as you go into the consultation is important. You have your difficult conversation, which we'll come on to in a moment. It goes wonderfully, hopefully. But actually there is comfort as you leave the consultation. So is that person with whom you've had the sensitive conversation, perhaps you've talked about time, perhaps we've talked about CPR, perhaps we've talked about the fact that getting up Snowdon at the end of August is not going to happen. Are you comfortable leaving the consultation? Have you closed it down? In your virtual, in your phone consultation, are you comfortable leaving it there? What is the person going to do next? Can you help them refocus into the world that they are just about to rejoin, having had a difficult conversation? So I think it's worth thinking about that a little bit as well. So for me, comfort is the physical and the psychological environment. A second tool, language. Verbal, of course, the words we use, how we use them, but non-verbal. So much of our communication is non-verbal. 55% of it is non-verbal. So actually, what are people picking up? What can you pick up from the patient and the family? Thinking, Katrina, about your comment around collusion. You know, you're there with the patient and there's somebody behind the patient saying, please don't say any more. Or there's somebody behind the patient who is quietly dissolving into tears and is very distressed, but the patient feels very strong. So what are you picking up? But also, what are people picking up from you as you're there? If I'm anxious, I find it very difficult to appear relaxed and to have what they like to call open, the open body posture. I want to tie myself in a knot because I'm feeling acutely uncomfortable and distressed about having to have a difficult conversation. So for me, there's often very active things I have to do to kind of unwind myself and to be there with the person. But it's also about how we speak the words and what language we use. And can you align your language, the descriptors, the adjectives with that of the patient? If the patient has used the word cancer first and it's somebody with cancer with palliative care needs, generally they will be okay if you then can use the word cancer. But sometimes if they haven't used the word cancer, you get into this really grey area of not being quite sure if it is somebody with cancer with palliative care needs. Is that a word they understand? They haven't talked about it yet. Is this denial? Is this collusion? How's this going on? So language it's so important. It's our language. It's the patient's language, but it's not just the words. But again, take this analogy out into phone consultations and virtual consultations. Is it any wonder that sometimes those are very much more difficult, because we're not seeing the whole of the person. We're not, in a sense, feeling the vibrations of the room. And of course we have to use them because they're really useful adjunct, as we've said. They've got a place, but we need to understand, I think, and acknowledge that there are bits in communication that we will miss by using that mode. So it's fine, we use them, of course we do, but we might not get the full picture. So sensitive conversations, generally there is better understanding with somebody in the room. I had to ring a son of somebody a few weeks ago who was in a different country, and gosh, silences on phones are difficult, aren't they? So this was silence on a phone from somebody from a different country, and it was very hard to gauge what they were feeling. I'll come on to silence. Yeah.
Comment in the chat, an interesting one from Lauren saying having conversations by language line can be very difficult. You've got an extra layer of difficulty there, haven't you?
Ah, what a great point, Lauren. Thank you. Absolutely right. And what does that mean for us? It means time, doesn't it? Because you and I think the challenge is that you phrase your question beautifully and sensitively, and then your interpreter will say it, and you hope that not too much has got lost in translation between there. So yes, absolutely. And I think the other interesting issue with language is if families are interpreters, because sometimes they are, and they offer, or neighbours, or, you know, it's again, like Katrina was saying with collusion, it comes from being a very well-meaning place, but sometimes is that person the right person to interpret, and what does the patient feel? I'm just going to pause there actually, and just again perhaps put that to everybody on the call. Family members as interpreters, how do people manage that? I can't say what do people feel about it, because sometimes there is no choice and they're there, but what are the issues that people find?
I mean, personally, I think that you need to judge it by each individual cases, and I think the main sort of thing for me is around actually having that patient's consent first of all, that that's how they want to play it, because there are lots of people who are more than happy to say, look, my family will answer all the questions, I'm happy to smile, and they will filter things through as they see fit, which feels it feels in sort of almost Western society, if I can put it that way, the wrong thing, because it's all about autonomy. But actually, for me, patients are maintaining autonomy because we're doing what they want us to do. The difficulty you have is obviously you don't speak that language, so you don't quite know. Sometimes you can hear, you'll pick up actually, yeah, that sounded like cancer in that language, or that's that's being said, but you need to trust that is what's being said. But there's the big cultural things around actually decision making, who makes the decision, and it's different in different places. And to me, I'm not sure that's wrong. I think the fundamental for me is making sure that somehow we've given that patient the opportunity to be the main voice, and if not, then you sort of gauge reactions. It's back to the body language thing, isn't it? That actually you can usually see if you're trying to break bad news and somebody is sat there smiling and laughing, you're thinking, what? I'm not sure what's actually going on here. Whereas if more of actually what you would usually expect, you can probably go along the lines of that. Probably more in line with what you're saying. I think Lauren's made another comment as well, saying that she's used it, but sometimes gone on to use language line as well, as unsure if the information in both directions is complete and correct. I think that's a really good point, isn't it? And if you're unsure, I think you're better off doing that personally.
I think that's a really valuable point, and particularly if you add in, I mean, we've got one complexity because of needing an interpreter. If you think about actually the theme of this webinar, which is the really difficult, the unanswerable questions, the difficult questions, that's an additional layer of complexity, isn't it? So in a way, anything that will help almost triangulate the information so that we know that we are trying to match the patient's wishes for their palliative and end-of-life care as closely as we can. And I think that cultural thing is really hard, because we are working in a UK environment, but potentially we are working within Asian or other culture communities. I've done a lot of teaching in India, and so I'm very familiar with a lot of the sort of the collusion and the collective autonomy. But my professional registration is also around the Mental Capacity Act as defined by UK law, and so I kind of have to tread that middle ground. Thank you. Those are really valuable points. Keep putting them in the chat. I'll move on to another couple of tools, and then again just add the comments in, and James then stop me when there are questions that we need to kind of discuss through. And Katrina, I shall bring you in the next time. So we've talked about comfort, we talked about language, and remembering that people remember the way you made them feel. They may not always remember your words, but they will remember how you made them feel. Question style. I think this is one of the most useful tools for these sensitive conversations. Now, all types of questions might be useful. So closed questions sometimes are really useful. Are your painkillers working? Yes or no? Sometimes we have to use closed questions. They will give us the information that is needed to be able to manage somebody's symptoms. But open questions give another layer. These hypothetical questions, fishing questions, is what Work by Ruth Parry called them in a wonderful bit of proper research. So the fishing questions or hypothetical questions are some people find in some situations. So if you're stuck in a tricky conversation and somebody is somehow you can't open up what people might want to be, what people might want to happen at the end of life, the closed questions seem to be quite brutal. Do you want to be looked after at home? Oh, that's a bit brutal, isn't it? For many situations, not for all, but for many. But open questions, particularly if people are frightened and are anxious, and this whole thing is just too big to think about, which so often it is, open questions are really daunting. You know, tell me about your thoughts about what you might want towards the end of life. For some people that works, yes, but for some people it doesn't. And so actually using these hypothetical questions or hypothetical scenarios can be really useful. And I bet everybody uses them, but we haven't quite worked out exactly, oh, that's a useful tool. But I've found that these sort of questions will open things up beautifully. Some people find that actually, as they're not so well, it's quite helpful to have a bit of extra care in the house. Some people find that it helps to actually think a little bit about what might be important to them. And then the person you're with can decide to take that cue or not. But if it's sensitive, kind of, you know, banging at a door that's not going to open tends to make the door a bit stronger. So trying to get information out of people who are not ready to give it is really difficult. So I think the hypothetical questions for me have been one of those really useful tools. And I'm conscious that in a sense, I'm using it more and more. And I'm affirmed in use, as I say, actually, just because there's some quite good evidence that it can be that useful unlocking tool. The next tool is around these letters, and these letters spell as well. Well, spell 3 words, as a wonderful colleague of mine said, but I'm actually thinking of silent, and I'm actually thinking of listen. And the purpose of putting these up is to just say we can't listen unless we are quiet. I know it sounds obvious, but actually generally for sensitive conversations, particularly around end-of-life care, the general perceived wisdom is that we should be talking for 20% and we should be listening for 80%. Now, I will be honest and say on a bad day, it's 50-50. If I can, it's probably 40-60. If I'm really switched on, it's 30-70, and on a good day, it can be 20-80. There's no doubt that if we ask the questions in the right way, people will tell us things. People will share their ideas. People will feel brave enough to share their ideas, which will help us all then to support them in planning their end-of-life care. They're only going to do it once. We only die once. Getting it as good as we can is really important for not only the person, but their family. And so trying to find a way to be quiet after we've asked that question is really important. But how difficult it is, because often, if you're time pressured, silence is feel anxious making. Generally, if you're a little bit anxious yourself, silence is also, the temptation is to fill it. But if we fill it, then the patient or the family can't fill it. And so kind of thinking of silence, actually, it's like a bowl, it's like a jug, and you want people to put their ideas in. And generally, after a silence or a pause in the consultation, what comes then from the patient or the family tends to be the most important thing for them, or the thing that is the foremost in their mind at the moment. So perhaps after you've reset somebody's expectations about what they might or may not be able to do, and there's a pause, hold your nerve and try not to fill that pause. Because sometimes people will then bring in, actually, what are they thinking? And if the silence goes on and starts to feel uncomfortable, which it can, actually then the useful tool is to say, you're quiet. Can I ask what you're thinking? Ask an open question. See what happens. Tool, 5th out of the 6 tools, not in any particular order. This is the other really useful tool in sensitive conversations. So when you're reflecting back a word or a phrase that the person has used. So perhaps you're with somebody who is clearly deteriorating, but they are not talking about prognosis. Or they're asking you about prognosis and it's all very, very woolly. And then they sort of say something like, oh, I've been really tired lately. And you could then say, okay, could you tell me a little bit more about feeling tired? Think about the 20-80 rule. If you just say tired, and forgive me, allied healthcare professionals on this call, because I put doctor here, but it could be anybody in these conversations. If you just reflect back that one word, tired, that can seriously open up people's concerns, people's expectations. So try it in a tricky conversation, just prompt with a word, but with a word that the person has used, because that shows that you've been listening. So reflecting back phrases shows that you've been listening, and that then instills a lot of confidence. And then the final tool, but definitely not always the final thing in that meeting or consultation, is summarising. So yes, of course, at the end, of course, that's what we do. So on this visit, in this appointment, we talked about 1, 2, 3, 4. But actually, if you get stuck in the middle, if you're halfway through, you're not quite sure where you're going to go with the conversation, it's really useful. So can I just get this straight? So what we've talked about so far is 1, 2, 3. It's really, really helpful to help you get on to that next step. So again, I think sometimes in these sensitive conversations where you might have a lot of information coming your way, but it's difficult to prioritize, difficult to know for that person what's the most important thing, summarizing can really, really help. So those are the tools that we will all be using in our conversations, and colleagues in Cardiff now in 2008 put those tools together to what we call the Cardiff 6-point toolkit. So these are tools to help you with your communication strategy. And I would actually say that they work for all conversations. They work with children, parents, colleagues, other team members, not just with palliative care conversations. So just a kind of a thought is just to try it, just observe, just to think about them and to try them. So I'm going to pause here for a moment and just say, so we've talked about strategies, we've talked about tools, we've talked about interpreters using language line. We've talked about, so I'm summarising now, we've talked about the sensitiveness of these conversations and how they make us feel. What other phrases or words do people use in tricky situations? And I'm going to bring Katrina in at this point, because I know Katrina in our webinar around prognostication, you found a terribly useful phrase that seemed to help conversations to flow. Do you want to say a little bit more about that?
Yeah, it's something I think it just came naturally. I was doing my master's on the Orwell's Guidance, Care Decisions for the Last Days of Life. And am I reading around a lot of these things? And you must have come across this lovely phrase about the possibility of someone approaching the end of their life, when you recognise that someone is dying and you're trying to communicate. And there's so much uncertainty, particularly with people with non-malignant disease, where we know that sometimes it's not always as easy as with cancer patients to be able to definitively say, yes, this person is actually in the terminal phase. And also if they've got, say, an infection or there's a potential reversible cause that we may have the potential to reverse. Again, it's that element of uncertainty. So it's a way as a healthcare professional to embrace that and say, yes, this is uncertain. We don't know what the outcome is, but there is the possibility that you or your loved one is approaching the end of their life, and allowing them to actually then sit with that and come back to you with those questions. And again, it's one of those moments where you use that silence and allow someone, you don't say anything after you said the comment, you allow them to come back to you. And if you've got to sit with them for a few minutes, then you sit with them for a few minutes. And they won't always break that silence with words. They will sometimes break that silence with maybe returning eye contact, maybe changing their position so they're looking like they're giving you more attention again. And like you say, with that non-verbal communication, it's really important that when we're having these conversations, we are present. We are present as much as possible for all of the conversations, so we can pick up all of the non-verbal cues to help us then start the next phase. But yes, it's amazing how just using that one extra word has really helped to start these conversations.
In a sense, it's sort of a little bit, it's introducing almost a bit of hypotheticalness, isn't it, into the situation. It's a possibility. It might not happen, but actually it might happen, and let's open this up. Absolutely. And I think it's hard, isn't it? I think particularly with people who don't have cancer, with the non-malignant conditions, as we talked about in a previous webinar. And folks do look at that webinar if you weren't able to join us, because it's there on the YouTube channel. Prognostication can be so hard, and sometimes it's general frailty. And I think for me, actually, sometimes the frail patient has a particular challenge, because it's very often somebody who has been very feisty and independent all the way through their lives until their mid-90s or whatever, and then the body is just not able to do what it did, but the brain, if they're not suffering from any sort of dementia or cognitive decline, is still absolutely sharp, but the body is letting them down. Katrina, again, I think you'd come across quite a useful analogy that was helping with that.
I have. It's a beautiful blog, and I will share it in the chat in a minute. It's by Patricia Cantley, who I follow on Twitter, and she does this wonderful analogy of the paper boat. And when she's talking with people regarding frailty, I'm just looking for the wonderful way. So she describes it as a fragile yet beautiful paper boat sailing around a pond of their choice. And during calm weather, and when weather is fair and there's no wind, that boat will happily sail on for a good long while. But if the wind gets worse, or if it starts to rain, then that frail wee boat, she is Scottish, would go over quite quickly with little that we can do. And it's a wonderful way of looking at that. And actually, she describes how she's used it with families and that the frail person, and it worked really well, and they found it very comforting, and they understood then just how their loved one can keep going for a long time, and then all of a sudden something that seems relatively minor can be the thing that precipitates them to approach the end of their life. And it's such a lovely image that they can hold then and get used to. I'll pop it in the chat, because she does describe then how she uses it with a family.
Right.
And the family then responded and said, sadly the paper boat went in the night, and it was really beautiful. They understood, they knew what was happening, and it's simple, but it's surprisingly effective.
I think that's really valuable, because I think you're right. So often, you know, families have lived through the ups and downs of their aging relatives. They may have been at the possibility of dying in the night, and actually up next morning eating breakfast. And so from the family's point of view, it's very much a roller coaster, isn't it? So there will come a moment when actually they're not going to be eating breakfast, and their heart might take its last beat in the night. And I think sometimes if families have had, it's that hope, isn't it? The hope, and it can be hard to actually recognise that actually this time it's not going to be like that. Again, one of these sensitive conversations. I'm conscious of time, because we're heading, dare I say it, we're heading towards 2 o'clock. Is there anything in the chat around any other useful phrases or words people use? Please do share your thoughts. As I say, comm skills, it's a lifelong professional and lifelong general journey, I think. Anything else there in the chat?
Nothing specific. Do you mind if I just make a couple of comments?
Please do, James. Yeah.
I would like the time short. It's just the things that I find helpful. And it's not to say, I think the first thing to say is that we all have bad days, and we all have conversations where it doesn't go well, and that, you know, I'm sure that there are patients who would say, I never want to see him again. But hopefully over time, and just with honing some of the skills, actually is that happens less and less. For me, the main thing in terms of communication, especially around difficult subjects, is that, I mean, our role is sort of empathetic honesty, rather than trying to make things better. You know, that actually most people, and you know, everything in life, I see things as bell-shaped curves. I probably shouldn't, but so there are outliers. But most people want honesty. They want to know what's going on, and that is actually calming and helpful for people. You know, when my dad was diagnosed with cancer and being unwell, he actually felt better, because he said, I knew there was something wrong, and I'm not going mad. So, you know, actually that knowing, we're worried about the knowledge, about what we're imparting the knowledge, but actually it can be empowering for somebody. So I think the first is to be honest with people if that's what they want. The other sort of tips that I would give is, actually, if we've got a consultation to do, and we've got information that ideally we need to get, sometimes if somebody asks a question, or gives a clue out straight out of the gate about something which you know is going to be a difficult Breaking Bad news type conversation, it depends on the situation, but often I'll try and almost say, right, I hear what you're saying, can I come back to that and just ask some routine questions in the meantime? And people seem fine with that, because you can gallop through the routine things, because you can't do the routine things after a really difficult bit of news. So, but make sure you do come back to it, so you've listened to them, and most people are fine with that. The other thing I tend to do is ask people, what kind of person are you in terms of communication? Do you like open communication? Do you like people being honest and direct? And I don't usually go by what they say. I usually go by how they react, because usually people say yes, but if they go yes, then I think, okay, I'm gonna tread here. Whereas if they go, yeah, of course, then actually you probably with somebody who would rather that. And as a junior doctor, I got sort of a lesson from a chap who I got on with really well. But I tried, you know, to be really gentle with my communication style and things with him when talking. And he turned around, he said, well, what are you, my shrink? He said, I thought you were my doctor. He said, just tell me. And so actually, sometimes we can try and be too gentle. So actually, as often I'll ask people, how do you want me to communicate this? I will check in though, if somebody looks upset, is saying, am I okay to carry on? And sometimes almost make it humor sometimes isn't good, but saying, look, you can tell me to shut up if you want. Literally, you can tell me to shut up. So give them the opportunity to actually stop you and say, we're done with this. And I find that reassuring for me more than anything else, and hopefully helpful for patients and family members to have that safe space to say, okay, we've gone as far as we need, but almost to call the elephant out in the room and just to say, if you want, tell me to stop. So those are, I'm going to shut up now because I realize I'm 80-20. I'm currently the other way around. But those are sort of my helpful hints that I've been writing down as we've been going.
But it is really helpful, and I think you've both raised a really important point, which is, how do you know? What do you look for? What are your red light warning signs when you're in a consultation, when you're in a conversation, whatever modality, and actually it's not going well? You've lost the person, you've lost that thread, you've lost that continuity, and it may be a simple thing like somebody loses eye contact with you while they are processing or thinking. It can be extreme. People can get up and walk out of the room. That gives you a really clear indication. If you're with somebody and a family member gets up and walks out of the room, that's just log that. You may be there on your own. You may not be able to do anything about it, but log it. They might have gone to answer their phone, yes, but actually what's happening around the person, is this communication going? Is this communication going well? So it's always useful, I think, to think about that. You will get copies of the slides. We put together the toolkit for PPE. We put together the toolkit for virtual. The tools work. All of the things that you would do face-to-face work in these other modalities, but slightly differently, and they're not the same. They don't have that same non-verbal. And as James said, bad news is always bad news. You know, it's bad news. You can't pretend that it's anything other than that, but we can manage the communications well. And managing uncertainty, which we haven't particularly talked about in detail yet, but it's just the key thing for managing uncertainty is being honest, but actually there are things that you can be certain about, and sometimes it is simply being certain about the uncertainty that will almost like be just pointers. So if you're driving a car in fog and it's all misty, you know, you don't want to put ice on the windscreen as well, but sometimes it can be as simple as, you can ask people, what if they ask, well, you know, how long have I got? What, you know, what do you think? What do you think's happening? You can ask people what they think. That's a really important question. I wonder why you're asking that at the moment. So answer a question with a question. Sometimes that works. Sometimes it feels a little bit ping pong and it doesn't work. But the other thing can be, you know, I'm with you. We are also uncertain, but there are things that we can look out for. And maintaining hope is a really fragile balance. But the thing is, it's hope for the patient. It's not your perception of what the patient wants. Hope might be as simple as, I will call you tomorrow. You know, because very often people towards the end of life, they're afraid that the world is going to desert them and they are going to be there on their own, and there will not be people there when they need them. And so actually hope can be as simple as, we will be calling. I'll ask my colleague to call. It's not hope that you're going to go on for another 20 years. We need to do a bit more work about that. You don't say it like that, obviously, but you know, but hope actually, you can recalibrate hope. And part of the conversations as people get frailer is about trying to recalibrate hope. Use the tools of the toolkit. Phrases to avoid if you can. And I say if you can because these phrases all come from our hearts. This is what we will be wanting to say, particularly that bottom one. I know how you feel if you're in a situation that's been very similar to one that you yourself has been through, but we don't. We're not the person. I can understand that this is difficult for you. I can sense how tricky this is, but I don't know how you feel because I'm not you. Try to avoid don't worry. What signal is that? What signal is that giving? That they're not supposed to worry, that it's end of life is coming? Try to avoid them if you can. It'll be all right. How will it be all right? They come from the heart. Sometimes it's really difficult not to say things like this when you're with somebody, particularly if they're distressed. But if you can reframe these words of compassion and of support into that situation in front of you, generally it feels more comfortable and you don't risk the backlash. Rainy day thinking is planning for the worst but hoping for the best. And just troubleshooting some of these usual problems in these conversations are you're acting on incomplete information, whether it's from the background information that you need before you go and see the person, or actually whether it's because people are withholding information because they don't feel comfortable with. You're pacing, you're not giving time, you're giving false reassurance. Oh, I'm sure it'll be okay. Probably not. Collusion can be a problem at removing all hope. But the other thing is forgetting to use your team. So around that person with their palliative end of life care, there is a team of people. We are all part of that team of people, including the family. So think about the team. If you're unsure how a consultation went, check back next time you go. I've done that lots of times. Next time I'm with a person, it's, you know what we talked about last time? I left the house feeling really uncomfortable. How did you feel? So actually use your team, use time if you can. We've talked about that. And things, as Katrina was saying, is just be in the present. If you've had a conversation that's been difficult, if you sense that your ways are diverging with the patient and family, get back to common ground. Think back, when actually did I last have eye contact? Should we just go back and talk about your pain? Think about what you're seeing and hearing. Focus if you can. If it's just that you're having a busy day, which we all have, actually, can you use a lot of mental energy to just be in the present? I think time, we feel really pressured, of course we do, but the time invested in these tricky conversations, particularly the first couple, as you establish what people want and what people's worries are, it's time well invested. But sometimes this bottom line is my bottom line. Actually, what's the aim of this consultation? So from a specialist palliative care point of view, if there's a referral for somebody who is not at all keen, doesn't want to see us, is worried about the word hospice, thinks that we're all about death and dying, and we're not, we're about the living bit as well. Sometimes actually that day, that moment is not going to be the one where the sensitive conversation is going to take place. Actually, I focus on being allowed to go back. I focus on the fact that I think that this person has got specialist palliative care needs. City hospice is needed, for example. So if I am too heavy in this first consultation and take it to sensitive things before that person is ready, there's a risk that we're not going to be invited back. And for support for our general practice and primary care team colleagues who perhaps asked to go in, that's not a good plan. That's not a good place to be. So actually, why am I there? What's the aim of that consultation? Okay, and I'm about to stop sharing, but just thinking as we begin this to a close, just think around these communication skills. What areas of learning do you want to develop further? What skills do you want to develop further? And I think at that point, going to just say, we'll put this slide up again in a couple of minutes time, but I think just 2 minutes before the end, sensitive conversations will always be sensitive conversations, and they should be, because every person we see, every family we see, end of life is unique to them. And so if it becomes just something rote, if it becomes something that we are overconfident in, that we get formulaic in, we're missing the point, because every communication style is unique. All of our communication styles vary day by day, sometimes hour by hour, depending on what sort of a day we're having. So they are, but for the person, their end of life journey happens once. And so time invested in them will be time well spent and will help the patient and the family really help this part of their lives to be as smooth as it can be. It may not be perfect, because life's not like that, but we can help make it as smooth as it can be by how we communicate. We would deeply like to hear from you. Please complete the evaluation. And before I stop sharing my screen, but the trouble with sharing my scaring my screen is that I can't see who is there. James, is there anything else on the chat? And if there are people there, are there last thoughts that you have and last thought that Catriona has?
No, nothing on the chat as yet. My last thought is not just don't beat yourself up if something doesn't go right. Just try and learn from it, and that's what we do every day. We as long as we can come out of that consultation saying I try to do my best and learn the bits that we can, I think that's all we can do. So, and I think if we don't try and have some of these difficult conversations, then I think we're doing a disservice, and almost if you're not having some which don't go quite to plan, you're probably not having enough conversations.
Yeah. That's a really good point. Thank you. Catriona, is there anything else that you want to add?
I think something that I've really taken away since starting in my role at City Hospice is learning from the others around me. I know there's phrases I picked up from you, James, that I use in some of my consultations as well when I'm chatting with families. There were things that I've picked up from you as well, Fiona. And sometimes, especially when we started having to wear all the PPE and our face was hidden more, I found when I wanted and I was feeling anxious, I gently gesticulate more to show that there is a calm energy. And I found by using this calm energy and trying to do it in a way that was trying to feel involving, it helped keep me calm so that I could keep the right tone of voice, so that we could then just go at the pace of the person that I was with. The other thing people have learnt off is other GPs, and I have had the pleasure of doing joint visits, and sometimes it's been completely by accident. The GP's turned up whilst I'm there, and sometimes it's been with someone I'm only just meeting for the first time, and the GP rocks up and knows this person, knows his family very well, and it's a real privilege. You know, in a City Hospital, we're meeting people right at the start of a terrible journey for them. They've either just had a diagnosis or there's been a change in their condition, and here rock up hospice care with this huge kind of warning sign that so many people find frightening. And then in comes this wonderful figure that they have known for years, who knows them, who knows the family, and they can sit there and the conversations are very comfortable. I've noticed in the particular ones I've observed, they know the language they use. There was already a little bit of gentle banter. So they're using humour appropriately to gauge the situation because they know that family. And it's really fascinating to just watch those wonderful communication skills coming through. And we all have these difficult conversations. We have them all the time. We don't necessarily think back and maybe reflect on those conversations and actually think about what we've done well and what we can do better. But as you say, going back and actually asking the person sometimes, how were you following the last consultation? It's amazing how often you can get really positive feedback on something you thought didn't go well because you weren't feeling comfortable. So please, you know, one of the things I will always say is learn off your colleagues, because everyone has their own little phrases or little ways of doing things which are absolutely invaluable, and you never know which one is going to come out of the toolkit and used in a particular situation.
Yes, language evolves. Well, James, go in.
Just to say, the bad habits were learned from me, Kat.
That's been a really, really interesting webinar. I think we'll bring it to a close for now. Just before we stop the recording, just again, all the recordings of the webinars and all sorts of other webinars are there on the Cardiff University CPD channel. It's open access, so do please go and explore various palliative care and communication skills resources, including community oncology. There's all sorts of things that were there through the pandemic and actually arising after the pandemic, so they're there for access. So I think we'll say stop the recording for now, Charlotte, and it's been an absolutely really